So it's my pleasure here to present at the 8th Bahrain Diabetes and Endocrine Review. And I'm extending my warm thankfulness to Dr. Wiam Hussein, who's the chairperson, for inviting me to give this talk. So basically today we'll be speaking about the thyroid guidelines. So when the thyroid meets pregnancy, what are the key endocrine decisions across gestation? So this is based on the 2025 guidelines, which was published by the Royal College of Obstetric and Gynecologists with the collaboration of the endocrine team. So first of all, before we start the guidelines, we have to know that basics are always important. So the thyroid undergoes extensive physiological changes during pregnancy, and that puts the thyroid at a very important corner, since the interpretation of the thyroid function test will differ based on the physiological changes that happens. So as you can see, through the beginning of the pregnancy, the maternal thyroid hormones undergoes an extensive physiological changes, as we do have the deiodinase 3, which is presented by the placenta, which degrades the maternal thyroxine. And the fetus is almost 100% dependent on the maternal thyroxine until the fetal thyroid gland become functional. Besides that, the pregnancy itself has its physiological changes. So we do have the increment in the estrogen, which will increase the thyroid binding globulin, and that will lead to an increment in the total T4. Plus that, the surge of the beta HCG, especially during the 10 to 12 weeks of gestation, which has the similar alpha subunit of the TSH, which also leads to a change in the TSH levels. However, the free T4 will remain a bit elevated initially, and then it might go down. So all those consumptive changes that happens during pregnancy give us a hint that we must have a pregnancy and a trimester-specific reference ranges, because the interpretation will differ accordingly. So previously, it was very well known that we do have a cutoff points for the TSH for each trimester. However, we have to reconsider the normal as the problem of this fixed TSH. Why is that? This was the work of Dr. Corvar and his team, which is a very well-known figure in the endocrine. So he reviewed more than 14 studies with more than 65,000 people. And as you can see, the upper limit of the TSH in those studies were actually well beyond the 2.5 and 3.5. So we cannot say that we do have a fixed TSH cutoff point for each trimester. So what are the newest recommendations? So to diagnose any abnormality of the thyroid function test during pregnancy, we must have a pregnancy reference ranges for the TSH and free T4. And if we does not have that, then we must have a TSH cutoff for in pregnancy. So this is the newest recommendation. So if you don't have a pregnancy specific reference ranges, please consider TSH of 4 as your cutoff point. So this is the different manufacturers of the TSH assays. So please make sure that the institute you work in, you can ask the lab which manufacturer they are using. So this is the different assays, and this is the different reference ranges, and you can put them as a benchmark for you. If you don't have such, then consider to have a TSH of 4. So the question now arises, so should all pregnant women be tested for thyroid dysfunction at pregnancy booking? Since we are going into autonomy and economics, and everything is speaking about money, so we have to put our patients and categorize them at higher risk. So no, why is that? This is because of the benchmark study, which is the CATS trial, which was done in the UK and Italy. So actually what they basically did is that they had 21,000 patients, and then they categorized them into half. So half of them were screened and they were treated accordingly, and the other half were not tested and not treated. And then they followed their children at 3 years of age to assess the IQ, and they found that there were no differences in the IQ scores of those babies of those women, either who were treated and the other half who were not treated actually. And also another study which was done for the subclinical hypothyroidism and isolated hypothyroxemia, which also showed no major significance between the two groups. So whom at risk? Those are the categories that we must screen. People who had a thyroid problem such as goiter or previous thyroid surgery, who are known case of TPO positive antibodies who underwent radioiodine ablation, or those with other autoimmune disorders such as type 1 diabetes, SLE, or others. And the other category is those who had a stillbirth or second trimester miscarriage, assuming that those were not tested at that incident. So the second question comes, so how should we care for a woman with hypothyroidism and subclinical hypothyroidism before pregnancy? So if you have a female who's no case of overt hypothyroidism or a severe subclinical hypothyroidism, which means a TSH above 10 with a normal free T4, so you should titrate your levothyroxine to keep the TSH in a preconception period of less than or equal to 2.5. The second is that those who are TPO positive before, and they are known to be subclinical hypothyroidism, which is a TSH between 4 and 10. You can also start levothyroxine and titrate it to be less than 2.5. Those with isolated hypothyroxemia, please refer them to the specialist, especially the primary care physicians. So if you see an isolated low free T4, just refer them to the endocrinologist to make sure this is not a central hypothyroidism or this is an isolated hypothyroxemia. So then we will deal with those patients. Actually, usually they does not require treatment. How to increase the dose? The increment of the dose should be 25 to 30%. So either you double the dose on 2 days of each week, or you categorize your patient. If your patient is taking 100 microgram of levothyroxine daily, then you can increment by 25 daily. If they are taking more than 100, then the increment will be 50 microgram daily. The third question is, how should newly diagnosed hypothyroidism, subclinical hypothyroidism, and isolated hypothyroxemia be treated during pregnancy? So if you catch your patient in the first trimester having a overt hypothyroidism or severe subclinical hypothyroidism, which means a TSH beyond 10, so please start treating your patient with 1.6 microgram of levothyroxine, and then you repeat the test after 4 weeks. If this is the dilemma that still it has not been resolved, which is if you find your patient with a TSH between 4 and 10, so how you deal with them? So the guidelines have split it into halves. Some says that okay, we will treat, especially in the first trimester. The other says no, you can follow up your patients every 4 weeks. Why is that? Because we still lack a very high studies that can conclude to which one is better. However, if you will ask me whom I will treat those who are at risk. For example, people who underwent hemithyroidectomy, people who have TPO antibody positive, people who underwent radioactive iodine and still they can had some reserve of their thyroid function test. Why is that? Because the thyroid itself, the remaining of the thyroid gland, will not be able to handle the consumptive hypothyroidism state that occurs during pregnancy. So you have two things. Either you can treat or you can wait, and when you will treat, you have to give 1 to 1.2 of microgram of levothyroxine, not the full dose, which is 1.6. Lastly, if you have an isolated hypothyroxemia, this does not require any treatment during pregnancy. Just follow up your patients every 4 to 6 weeks until 20 weeks of gestation. So this is a summary of what I said. So if you have an overt hypothyroidism, you directly start. If you have a subclinical hypothyroidism, if it is more than 10, it's recommended to start. However, if it's between 4 to 10, you have two options. If it's diagnosed in the first trimester, it is considered highly recommendation to start. However, you still can wait and monitor your patient. So you have to classify your patients according to their background, and then you can start them, or you can delay and just follow them up. So how the thyroxine will be titrated during pregnancy and after birth. So for the pregnant ladies, you have to follow up your patients every 4 to 6 weeks until 20 weeks of gestation, and then you can just repeat the TFT once at 28 of gestation, which is just before delivery. And your aim is to keep the TSH below or equal to 2.5 while keeping the free T4 on the upper normal limit of the trimester and manufacturer specific reference range. Following birth, if the patients prior to pregnancy were adequately replaced, you can revert them back to their preconception levothyroxine 2 weeks postpartum. So 2 weeks after delivery, you can tell your patients to go back to their previous doses which were prescribed before pregnancy. If the woman, she was not known case of hypothyroidism, so she just had the hypothyroidism during pregnancy, you can safely stop the levothyroxine and check the thyroid function test 6 weeks postpartum. So always the question says in the guidelines in Bahrain, they still do the TPO antibody. So should an euthyroid female be tested for TPO antibody or not? So this is based on the studies. As you can see, they checked the miscarriage rate of those female who are euthyroid and have a TPO antibody positive, and they found that the thyroxine treatment for those ladies did not decrease the miscarriages rate. And also, they checked it for the thyroid autoimmunity, the overall for the preterm delivery, and they found that even levothyroxine will not decrease the rate of preterm birth in euthyroid TPO antibody positive. And they tested that on the placenta abruptia, the live birth rate, and also the clinical pregnancy rate. And also, there was no improvement in the clinical pregnancy rate in any euthyroid TPO positive females. Why is that? This is, we have to know the physiological background behind that. So not all positives are equal. Why is that? Because as you can see from this study, they found that the premature delivery risk is increased by 1.7. However, the response to the TPO between patients differs because of the underlying physiological changes. So there were two main hypotheses why this has happened. So they said either the TPO antibody positivity leads to a premature delivery. The other mechanism is the thyroid autoimmunity leads to a low thyroid function, and that low thyroid function leads to premature delivery. So as you can see on your left side, this is the TPO antibody negative. So they assessed the TSH response to the number or the amount of the beta HCG surge. So those who are antibody negative, they responded very well to the increment in the beta HCG throughout the weeks of the pregnancy. So as the beta HCG increases, the free T4 increases, and that was the normal physiology. However, on your right side, the TPO antibody positive, they did not respond well to the increment in the free T4 in regard to the elevation in the beta HCG. However, when they did the plotting, so they did the plotting of those patients, you can see we do have three different categories. So we do have those who responded very well, which is in the circle of green, and those in the middle, and those in the red, which means not all antibody or TPO positive females responded the same. So it is not the TPO itself, it is the thyroid gland how does it respond to the physiological changes during pregnancy. So that's why from there they ended up saying that the TPO antibody itself does not signify that those ladies are of more risk to have a hypothyroidism during pregnancy. So as you can see, we do have high, the above mean, the below mean, and the low red, as I say to you. So we have different responses according to our different patients. So what are the newest recommendations? So the routine testing for antibody, TPO antibody during pregnancy is not recommended. And if a woman is non-case of TPO antibody, then if they are in the first trimester and you catch them having hypothyroidism, it is better to treat them. However, the levothyroxine for all those who are euthyroid is generally not recommended. So let's go to the other extreme, which is the hyperthyroidism and thyrotoxicosis. I believe that those patients actually they are not seen in the primary care, they are referred to the secondary care. However, it's very important to shed the light on that, because usually the primary care physicians, who are the people who are seeing those pregnant ladies, those are the first encounters of the first booking of the pregnancy. So they have to know a very good background about that. So why we are afraid of the hyperthyroidism during pregnancy? Because it is very well known that hyperthyroidism carries a significant risk on the pregnancy itself. So some literature says that it is because of the drugs itself, the antithyroid drugs. The other says it is because of the antibodies, and the other says is because of the hyperthyroidism itself. However, we know that if a lady has a hyperthyroidism and the pregnancy is a consumptive hypothyroid state, so it won't be a problem. However, they found that the main problem is that because if a patient is having Graves' disease, the amount of antibodies will go and stimulate the fetal thyroid, and that what causes the problem. And the cumulative of the drugs that actually will lead to the problem and the adverse outcomes in pregnancy. And it is very well known that it increases the risk of preeclampsia, stillbirth, and the maternal admission to the ICU. So the risk is directly correlated with the level of the antibodies. So this is a very important point, because you have to know your patients. So not every patient is similar. That's why it's very important to measure the TRAb titer for our patients, because this will classify our patients according to the treatment. So if you have a patient that has a very high TRAb level and she is in the productive age and she wish to become pregnant, it's better to send her for surgery if she fits that, because the level of the TRAb will normalize very fast after surgery. However, if she underwent radioactive iodine treatment, it requires at least 6 months for the TRAb to normalize. So you have to weigh what does your patient prefer. So some ladies, they prefer not to delay their pregnancy for beyond 6 months. So if that is the case, then send them for surgery better than send them for a radioactive iodine ablation. So as I said, this is the point I said. And if the woman continues on antithyroid drugs, which is the PTU, which is recommended in the first trimester, so they found the PTU has no increase in the teratogenicity. However, it is the cumulative dose that leads to a teratogenicity in the pregnancy. So the free T4 concentration should be maintained on the upper half of normal for each trimester. So what is the optimal care for a woman with Graves' hyperthyroidism during pregnancy? So when the female is pregnant and pre-conception, she is using a carbimazole, you have to switch her to PTU, and the ratio is 1:20, which means if the patient's taking carbimazole is 10 mg, then you convert her to a PTU of 200 milligram. If the antithyroid treatment is required, so PTU is the recommended medication in the first trimester, especially for women who presents earlier, less than 10 weeks of gestation. If the female presents beyond 10 weeks of gestation, then there is no benefit of switching her to PTU. Just keep her on the carbimazole, as the PTU has increased risk of hepatotoxicity. And you have to titrate your drugs so you can achieve a free T4 that is in the upper half of normal according to the trimester specific. and you have to just screen your patients with serial ultrasound Doppler at 26 to 28 of gestation, and you have to measure the TRAB as well in the first trimester. This is mandatory for all of your patients, and if it is above the threshold, then you can measure it again prior to delivery at 20 to 28 weeks of gestation. So then, how should the woman with a history of hyperthyroidism be cared postpartum? So thyroid function test is required 6 to 8 weeks after birth for those who have existing hyperthyroidism. Both carbimazole and PTU are considered safe during breastfeeding. The lowest effective dose should be used with monitoring of the child growth and development, and consideration may be given to administering the total daily dose of carbimazole or PTU in 2 or other small doses per day. So this is the summary of recommendation. So if you have to use the trimester and SA specific pregnancy reference range. If you don't have so, then use 4 as your cutoff limit. In overt hypothyroidism, there is a high maternal and fetal risk, so we have to treat immediately. If we have a severe subclinical hypothyroidism, which means a TSH of more than 10, then you have to treat at any gestational age. If you have a subclinical hypothyroidism, which is a TSH between 4 and 10, you can consider, especially in those who were diagnosed in the first trimester or those who have a TBO antibody positive, those who underwent hemithyroidectomy as well. If there is a mild TSH elevation below pregnancy reference range, then there is no need for treatment. Eothyroid with isolated TBO positivity, also, it's not recommended to treat them, and you have to maintain the free T4 in the upper normal of limit for those who are hyperthyroid. And for those with subclinical hyperthyroidism and gestational transient thyrotoxicosis, there is no need for treatment. One last message before I end. If you have a female that is, she's maintained on a low dose of carbimazole before pregnancy, for example, 5 mg for the last 6 months, then you can safely stop this medication and allow the female to go into pregnancy, because she will not be in a hyperthyroid state, as the pregnancy is considered a consumptive hypothyroid state, and then you can just follow her up within 4 to 6 weeks of pregnancy. And thank you.